Welcome everyone to today's webinar, Redesigning Acute Pain Management to Provide Quality Patient Care. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Jimmy holds numerous responsibilities and oversights in his role as Director of Clinical Integration at Beth Israel Deaconess Hospital, Plymouth. He is the Director of Clinical Pharmacy Services and is an adjunct clinical pharmacy professor for 6 colleges of pharmacy in New England. The Massachusetts Society of Health Systems Pharmacists named him Health System Pharmacist of the Year in 2015. He was also named 2015 Clinical Pharmacy Preceptor of the Year for the University of New England in Maine. At BID Plymouth, Jimmy serves as the Director of the Clinical Pathway Committee, Clinical Administrative Director of the Hospitalist Service, Co-Chair of the Pain Stewardship and Antimicrobial Stewardship Committees, and sits on all medical staff committees. In 2016, BID Plymouth was one of 115 hospitals in the country and only one of 2 acute care hospitals in Massachusetts to be named a top hospital by the Leapfrog Group. In 2017, BID Plymouth was named to the top hospital list again and was the only hospital in Massachusetts to repeat. Top hospital designation is one of the most prestigious distinctions a hospital can receive in the United States. Numerous quality and safety protocols and policies which contributed to this award were formulated in the committees named. Jimmy is an active member of the Massachusetts Health and Hospital Association's Substance Use Disorder Prevention and Treatment Task Force. He participated in the formulation and recommendations of the Opioid Management Guidelines. His major contribution was coordinating the collaboration of members of MHA, Mallinckrodt, and clinicians from BID Plymouth to create the Educational Pain Stewardship Educational Pain Stewardship Program. So Jimmy, I'll turn the floor over to you now.
Thank you very much, Mackenzie. I appreciate that introduction. I think the only reason that the list is what it is because I've been around a long time. It has nothing to do with anything other than age, I think. For the folks on the line, I appreciate your time. I'm sure over your lunch, so we can share a few thoughts around acute pain management. As you can see, beautiful BI Deaconess Hospital in Plymouth. We can see the Cape Cod Bay in the distance, but I'm sure, like all of you who might be practicing in states with mountains or by the seashore, that most of us get to work in the dock and get to go home in the dock. So we don't usually get to see the ocean too often. But ultimately, we're happiest about our designation as a Leapfrog Hospital. We were given 4-star recommendation from CMS, and as I say, it's not just the leaders. We can dream these things up all day long, but it's all of the ancillary services and the collaboration that we build amongst each other that makes us successful. So I'd just like to share a few thoughts with all of you over the next hour regarding the landscape of pain management. So initially, I thought this would be an easy slide for most of you. The opioid epidemic is in the news just about every single day. This slide is a little dated, but if you go to the CDC website, you will see lots of information around the opioid epidemic. This is very telling, and I think a good slide to illustrate that. And this basically shows the drug overdose death rate. And so this is total drug overdose death rate for 2015, which was published in December of 16. So you can see that there were about 52,000 folks that expired to drug overdoses, and 60% of those were involved with opioids. The deep purple, you can see that the rate per 100,000 folks that passed away. And just recently, I came across the updated guideline, which was published in December of 2017. In 2000, so I just want to fire a few statistics by you just to give you a flavor of what we're dealing with. In 2015, the top 5 states were West Virginia with a rate of 41.5%, 41.5, New Hampshire 34, Kentucky 30, Ohio 30, Rhode Island 28, and Massachusetts around 26 deaths per 100,000. Now in 2000, so as I said, the new data that came out, which you would think that we would all decrease that those levels. West Virginia was still at 52, Ohio 39, New Hampshire 39, Pennsylvania 38, Kentucky 33, and Massachusetts increased to 30 deaths per 100,000. Now the death rate in 2016 was 63,600, which as you can see is an increase from 2015. And also the death rate from opioids increased to 66%. So from 60% to 66% in 1 year, you would think that would go down. The number of deaths that equates to in 2016 was around 42,000, which was almost doubling from the deaths from opioid in 2010. So in this short time frame, with all of the initiatives that we have in every single state, you would think that, you know, we would be decreasing that rate. The average number of deaths per 100,000 in 2016 was 19.8. So you can see that many of us are over that particular death rate. So a lot of work to do. As I said, just in one of the recent listservs, which came out yesterday, the state of New Hampshire had approved $50 million over a 5-year period to the hospitals in New Hampshire to fight the opioid epidemic. So many states are putting in initiatives to fight the opioid crisis. So as we go forward, you know, how do we manage pain and re-educate how we take care of pain in the changing quality landscape? Well, as of October of 2010, when the Affordable Care Act was put in place, which seems like yesterday, but almost 7 years ago to date, we have the evolving paradigm of patient care, which should have been the paradigm of patient care years ago. So if you can picture the patient in the center, we're going back to patient-centered care, and you surround the patient with quality, safety, the experience of care, and improved value. These are all different elements that we have to improve on in order to create that improved paradigm of patient care. And along with the Affordable Care Act came our accountable care organizations. So value-based purchasing. So looking at value-based purchasing, we were fortunate down here in Plymouth that when the accountable care organizations were formed, we were one of the first 27 Medicare shared savings programs in the country in Little Plymouth. I was very fortunate to have a chief medical officer that I worked very closely with who filled out our application. We had our accountable care organization was with our larger physician group, PCP group, a smaller group, as well as the hospital. There were 32 pioneer ACOs at that time, but it was truly a change in the way we practiced, where in the past it was all fee-for-service or volume-based purchasing, and then we had to create all kinds of clinical pathways from the physician's office all the way through disposition when the patient left us. We've created clinical pathways in the past from when the patient landed in the ED until they were discharged. We didn't care where you came from or where you were going because we weren't concerned, because we were not expected to evaluate the cost in managing the patient. But now with fee-for-service moving towards value-based purchasing, how do we get through that successfully? And that's critically important, how we look at our pain patients, how we treat pain. You know, we don't want patients to be readmitted. We don't want to send them to a skilled nursing facility if we don't have to. We want to give them the appropriate tests and studies while they're in the hospital and the appropriate disposition when they leave. Well, as we go forward, we kind of joke about this a little bit. It's CMS and Medicare. Do they give us they call it an incentive. So the incentive is obviously to create high quality care and safety. But is it an incentive or is it a penalty? Well, it depends on how you look at it. We obviously, every single hospital in the country wants to create a safe, high quality and safe environment. But in many instances, the only way to get that done is to attach financial penalties to that. So as you can see over the years and through 2017, there's been an increase of about 6%, which we were at risk for. And that includes 3% for hospital readmissions, 1% for hospital-acquired conditions such as CAUDIs and CLABSIs. Value-based purchasing has increased the risk to 2%, and I will have a slide to demonstrate that. There are certain voluntary programs that are the Medicare Shared Savings Program, Healthcare Innovation Awards, and bundled payments. As you know, with the Trump administration, there have been many changes and challenges for the Affordable Care Act, and most recently in December of 17, the bundled payments, which had included total joints, which was mandatory for 67 markets, was decreased to 34 markets to be mandatory, as well as making the other 33 markets voluntary. And they kind of nixed the cardiac bundle payment, as well as adding fractured hips. So a lot of changes with the Trump administration as far as value-based purchasing and the Affordable Care Act, yet the core is still in place, and the concept of us meeting those quality and safety initiatives are still in place. So as we speak of readmissions, and we talk about pain management, this particular study, there are numerous studies that will illustrate the increase in readmissions and how we've treated patients with opioids in the past. This particular study was performed by T.J. Gann, who is the chair of anesthesia at Stony Brook in New York. And what this group looked at is they looked at Premier data, and they took the Premier data and looking through ICD-9 codes, which were in place at that time, they looked at data from 2008 to 2010, patients that had major bowel surgery, whether it was open or laparoscopic cholecystectomies or colectomies. What they found is that 138,000 patients fell into this category, and approximately 10% of those patients ended up with an ileus, which caused them to be readmitted. So looking at this patient population, they looked at the morphine equivalent doses that the patients received. And as you can see in the dark green, if the patient received greater than the median of the MEDs, they had a higher readmission rate than the light green bars, which had a lower administration of morphine equivalents. In this, for any of the clinical folks on the line, you know that this is evidence that with major, small, and large bowel surgery, that this is a complication. There are many complications with that type of surgery, but it is most definitely confounded by the excessive use of opioids. We have a general surgeon here that uses multimodal everything in all concepts of the agents that he uses, and he has seen a significant reduction in ileus to the point where he uses Entereg in almost every one of his patients. We've created in our software program, we've created an automatic discontinue of Entereg with the nurses assess the patient. So therefore that we can discontinue this medication because he uses such a limited amount of opioids on these patients postoperatively. But another element of the process is not only are these patients admitted more frequently for ileus, but their length of stay is extended up to 2 or 3 days. So very important that we monitor the utilization of opioids and try to implement that multimodal analgesia. So let's switch gears a little bit, and as we talked about, the changing paradigm, we have to look at patient experience. So I'm going to go through the historical aspects, which I'm sure that every hospital, the folks on the line, that in most of your departments, you have your HCAP scores and how each department fared and where the improvements can be made. And this is a significant challenge for every single one of us, trying to maintain the same quality of care through a 24-hour period or through an entire length of stay is difficult. But initially, the HCAHPS scores were included in the value-based purchasing scoring back in October of 2012, and they're available on the Hospital Compare website. So as you know, the benefits of the HCAHPS were that this was a place where we could produce data for patients' perspectives of care. The most important thing that we have is, what we might think we're delivering great care, but obviously to a patient who sees 4 or 5 different providers who don't introduce themselves, they don't know whether it's their hospitalist or their cardiologist or what clinician is in the room. It's very important that the patient is communicated to at all times. The public reporting is important for the quality of care. None of us want, if you can go on to onto the website and look at how we compare hospitals, it's very easy to see that we want to have, every hospital wants to have high scores, and it gives us an accountability through transparency. So there are 9 dimensions. Pain is one of those important dimensions of HCAHPS scores. And as you can see down below, the issue around pain it came around 2016, where just looking at a focus of patient satisfaction and pain management has been viewed by some as the driving overuse of opioid monotherapy, resulting in increased adverse events. So the history behind that is that back in June of 16, many physician groups presented at the American Medical Association, and they felt that they were really pressured by their hospitals and by their patients to be prescribed opioids for pain. And the big cry at those meetings was that Joint Commission way back in 2001 had developed pain as the 5th vital sign, and the physicians wanted this to be removed, and they felt pressured for this to happen. And they felt that if they didn't give their patient opioids, that the hospital would receive poor HCAHPS scores, which ultimately would receive penalties and payments. Well, the discussion went on in July and November of 2016. Sylvia Burwell was the Secretary of U.S. Health and Human Resources and Services, and basically they discussed this at length, ad nauseum. They weren't sure whether this would be efficacious at that time, but ultimately the decision came down that for 2018, as of January 1st, 2018, that the pain management dimension would no longer be factored into the hospital reimbursement. So the value-based purchasing, although it was stated at that time that it was a very small margin that was incorporated, that they would remove it so that there was no perception that physicians were under pressure to order opioids. And during this time frame, as we go forward currently, CMS is going to collect data to evaluate whether the opioid prescriptions have decreased. Now, that being said, just to remind you, the questions that were in place at the time were during your hospital stay, did you need medicine for pain? And as you know, the scoring is never to always, and if you don't get always as an A+, and if you get anything else, you flunk, basically, and it's very difficult to have patients check off always. So during your hospital stay, how often was your pain well controlled? And did the hospital staff do everything they could to help you with your pain? Well, this goes back to the discussion back in April of 2014, which was ultimately approved, as you can see below, that it would start in January 1st of 2018 and ultimately would not be publicly reported until October of 2019. But as you can see how the questions have changed and how the twist in the questions are basically a communication to the patient. During your hospital stay, did you have any pain? So querying the patient, did you have pain? How often did the hospital staff talk with you about your pain? So more communication. Then how often did the hospital staff talk with you about how to treat your pain? So it's just kind of a twist on how we're factoring in the questions, and the questions will still be there, because for any hospital, for any of our committees, our pain stewardship committee, our clinical pathway committee, it is critically important that we know what the patient's perception is of how we're treating pain. They've just removed the component of where it's going to be factored into value-based purchasing. So as part of, and basically, for all of you folks who this has been in place for now for a couple of months, you know, what we have our patient care advocate who is part of our pain stewardship committee. We actually have her starting to meet with our nursing service with all of our shifts to explain the changes in the questions, because there has been data and statements that have come out from various resources that state that the nurse who is at the bedside is the most important clinical practitioner who can have the biggest impact on communicating with the patient and explaining to the patient that you will have tolerable pain, and receiving conversation from the patient of how they can address their pain. So very important that we communicate these changes to our staff. Now, as I said before, when we talked about that, the Medicare withholding of 6%, 2% of that was for value-based purchasing. And the point here, as you can see, this started in fiscal year 2013. And the piece of the pie, as we started out with the value-based purchasing, we want you to illustrate the fact that it was 30%. It was a very large portion of the pie from the very beginning. So as we put together our accountable care organizations and how we went about changing the paradigm of patient care, you can see 30% in fiscal year 13, 14, 15, and as we went on to 16 and 17, it became 25%. As you can see, if you go back to 13, if you can see the incentive for us to meet our goals was a 1% withholding, and it increased by 0.25% all the way to 17, which that is where they came up with the 2% that they have come up with now. To illustrate what that withholding was in 2014, I have the data that they withheld from hospitals that participated $1.1 billion, and they reallocated it to hospitals that actually made the grade. So it's a significant amount nationally of the money withholding money, but the fact of the matter is that they place a very high value on the patient's experience. And even though the pain dimension is not included in value-based purchasing, all of the other dimensions are. So as they determine what the scoring mechanism is for value-based purchasing and the pain dimension, as you can see, what CMS does is they take the performance period, which was 2016, for fiscal year 2018, and they create the achievement thresholds as well as the benchmarks. So a ways to go to meet those benchmarks. In a very interesting study, which is one of the reasons we decided to put together our Pain Stewardship Committee here at PID Plymouth, was this study which was performed by Anita Gupta, who comes from University of Penn in anesthesia and critical care. What she did is that her group evaluated 2,500 hospitals when the HCAHPS scores first were published way back in 2008. And what they found, they evaluated patients that gave very high scores in pain management. And it really makes sense. If the patient is comfortable and their pain is well controlled, they found that they scored every other dimension extraordinarily high if they were comfortable in their pain management. So it makes sense, and this is why this is one of the more important indicators that we follow, is that yes, we have to control pain. And just think about it yourself. If you're lying in bed and you're in agony or you're uncomfortable, there's not many, communication with doctors, nurses, or anything is not going to score highly while you're writhing in pain. So we have to be very careful how we control the patient's pain, but this is just to illustrate if it is controlled that patients tend to give higher HCAHPS scores. So switching gears again a little bit and to look at, with the Affordable Care Act, with hospital management, how do we change to achieve that quality and safety that we were looking for and standardize our care? Well, one of the mechanisms that we've utilized in the past in the literature is the utilization of clinical pathways. Clinical pathways in most institutions are using the evidence-based literature that come from the Evidence-Based best practice guidelines, implementing those into your computerized order sets. You know, and as I said before, now we have to be cognizant of what's happening in the PCP's office as well as disposition when a patient's discharged. Many instances would like the patient to go home to home, maybe with services, but we have to carefully think about how we build these order sets. So what we're looking at when we're evaluating the data that we've looked at, obviously length of stay, discharge to the appropriate site. In some instances, we may keep that patient a day longer to work with PT and send the patient home rather than send them to a skilled nursing facility. These are some of the thought processes that go along. Discharge to the appropriate site, readmissions, and adverse events. So the need is that we have to redesign the way that we, you know, our old order sets with the pain management were utilization of opioids throughout. And that truly is not the way that we should be utilizing it in today's standards. These are very interesting studies that were done in the current state of acute pain management. And our pain care still is suboptimal. So opioids are have been the traditional foundation of acute pain, and there are multiple surveys that were done. The data here is from 3 different studies that were done. One was in 1995 by Carol Warfield, she was worked actually in Beth Israel Deaconess Medical Center in Boston, who is our mothership. Basically, she worked in the pain center there. They evaluated 500 patients who had their, and they asked the question, they surveyed them randomly, do they have any pain or surgical procedures within the last 5 years? So that's a long period of time. I think I'm lucky if I can find my car when I leave here. But basically, most of the queries came back within a 14-month period that patients had their last surgical procedure. They asked them what degree of pain they had. So, and the results are printed there. So in 1995, it was 500 patients. It was repeated in 2004 by Applebaum and his group, and that was 250 patients, and more currently by TJ Gann again with 300 patients. So about a total of 1,000 patients were queried, and the results were almost identical for each particular study. And so 44 to 51% of the patients said that they still had moderate pain in once they were discharged in that immediate postoperative period, and 8 to 22% of the patients still reported extreme pain. And so that's still clearly, with this information, we have a lot of work to do. Another important study, which came from Laura Pizzi, who's a PharmD at Thomas Jefferson, and Jean Viscusi, who's written published many articles on pain management. But what they looked at, Thomas Jefferson, was balancing the administration of opioids with the adverse drug events. So this study looked at approximately 400 orthopedic patients, 100 patients that had total knees, 100 with total hip, 100 with spine, and 100 with total shoulders. And they looked at what the adverse drug events were from the opioids that they had received. They took all of the opioids in the perioperative and postoperative period, and the morphine equivalence was approximately 60 milligrams per day. And what they did is they evaluated the adverse drug events for these particular patients. So they found out that in this population, 54% of the patients had at least one adverse drug event, 26% had at least 2 adverse drug events, and 7% had at least 3 adverse drug events. And so what did that lead to? Well, if you look at basically the top 3, the usual discharge length of stay for these patients was around 3 days, as you can see with the dark green bars. Now, those that had adverse drug events, you can see for constipation, it was around 7% of those patients had constipation, 4% had confusion, and approximately 13% had emesis. But you can see how those adverse events extended the length of stay. So it was 0.7 in emesis group, 1.1 in the group with confusion in 1.4 days. Now, if you look at HCUP data, usually a med-surg length of stay in a median-sized hospital is about $2,300, somewhere around there. So if you multiply, say, $2,000 to $2,300 per day for the number of patients that have had these procedures in your own institution, you can see that the utilization of IV or PO opioids, that we have to look at the broad spectrum picture, that not the cost of the agents themselves, but ultimately what is the result. I'm sure that all of the clinical folks in the audience that who have been around for a while, that all we did in 25 years ago was look at the medications that we could administer to patients in the PACU because of the nausea and vomiting that was created. Zofran wasn't even around in those days. We were all looking for droperidol and Decadron and rarely giving Compazine or Tygan for the historical buffs. But as you can see, we're all looking for medications to treat the adverse event, where we should be flipping the whole treatment of this pain to what other agents can we use to treat pain rather than opioid. So what are the benefits of multimodal analgesia? Well, it's been proven in the literature that we can reduce doses of analgesics in the treatment plan. Theoretically, the important piece is that if you utilize any of these other non-opioid analgesics, we should be reducing the initial doses of opioids in our order sets. We actually even made that mistake when we first started using multimodal analgesia here. We had higher doses of morphine IV, higher doses of Dilaudid IV, that we should be reducing those if we're using non-opioid analgesics to begin with. Obviously, multimodal analgesia, you're using more than one agent, you get a synergistic effect. There are fewer analgesic gaps. Patients are more comfortable at rest and activity, with multimodal analgesia, and that's what we really want. We want to improve functional outcomes. We want the patient to be up the day of surgery. If you have a total knee done at 8 in the morning, by 3 in the afternoon, you should be up and working with PT. And we have a lot of our 60-year-old jocks who have knees replaced are going home the next morning. So the pain is controlled very well. We can reduce length of stay and obviously improve patient satisfaction. So as my role as directing the clinical pathway committee, as I said before, our goal for whatever whether we're looking at community-acquired pneumonia, sepsis, heart failure, whatever we're looking at the evidence-based guidelines and who is supporting. What is the most current evidence-based guideline to support the development of these order sets in these clinical pathways? Well, in the beginning, a few years ago, there was only a few societies that were endorsing multimodal analgesia. But as you can see right now, it's almost everybody. It's the Society of Hospital Medicine. It's our anesthesiologists, our emergency room physicians. As you can see, the regulatory agencies, the Joint Commission, the Society of Critical Care Medicine, ERAS, it's the Geriatric Society. So therefore, not only we should be looking at the post-operative period, but we should look at what happens when our grandparents come into the emergency department and they may have fallen but not broken a hip. Do we give them Dilaudid? Do we give them morphine? Or maybe should we giving them a non-steroidal or maybe acetaminophen IV or PO? We should be looking at that very closely, that we start out with non-opioid analgesics, but it's supported by all of these societies, which I think is critically important. Incentives to support change. So there have been numerous initiatives that have come out in the past. I'm sure you've all read the Joint Commission that sent out their Sentinel event alert in August of 2012. Basically, we utilize these risk factors for respiratory depression. We utilize that list of risks when we evaluate our Narcan study, which I'll talk about in a little bit. But there are multiple recommendations of how you should be utilizing opioids and non-opioid pharmacologic and non-pharmacologic treatment of pain in that particular Sentinel event alert. Also, in 2015, they sent out an alert basically to incorporate non-pharmacologic and pharmacologic strategies for treatment of pain. CMS has sent out various memorandums, as well as the HCAP scores that we discuss in the Institute of Safe Medication Practices. All have sent out various emails, various directives in how we should safely deliver the treatment of pain. So just to digress to some of the nuts and bolts of multimodal techniques, obviously you're all aware that we're utilizing 2 or more analgesic agents that work at different aspects of the pain system. And the important information comes from our anesthesiologists. They started out their guideline. Their initial guideline was around 1995. It was updated in 2004 and most recently in 2012. But as you can see, the recommendation, which should be incorporated in every hospital in the country, is that unless contraindicated, patients should receive around-the-clock regimen of non-opioid analgesics. So that's the NSAIDs, the Coxibs, Celebrex, acetaminophen, and it should be supplemented with regional anesthesia. As you all recall, in the distant past, when we were using analgesics, they were all PRN. So the patient would have to be leaning on their call button, waiting for somebody to treat them. But now, obviously, for these patients who have acute pain, that we should be giving around-the-clock administration of these agents. So where do these agents work? Well, the different classes of agents. In the periphery, we see the local anesthetics. So those are where we have bupivacaine. Some of us use liposomal bupivacaine, which is Exparel, which is very effective. We have the NSAIDs and the Coxibs that are very effective in the peripheral for peripheral pain. You go into the dorsal horn as we go up the pain pathway. Here's where the local anesthetics work. Again, opioids start to have an effect. We have the alpha antagonists, which include clonidine and dexmedetomidine. We have the NMDA antagonist, ketamine, as well as magnesium ions. And just most recently, I'm sure that all of you are experiencing outages of hydromorphone and morphine syringes, which is truly beneficial to our multimodal task, but we're forced to find new ways to treat pain. We just recently implemented ketamine for IV analgesia to be administered by RNs in our emergency department and our critical care areas. So protocols that we've picked up from across the country and truly effective for patients who are on chronic opioid therapy. NMDA agonists are really effective in utilizing ketamine in this particular patient population is very useful. Also in the dorsal horn, we have the gabapentinoids, gabapentin as well as pregabalin start to work, and all of those agents continue to work in the central nervous system as we move up the pathway, including acetaminophen at that point. But we should be incorporating all of these different agents and combinations of these agents. And this slide just illustrates that I didn't miss anything from the last slide. So those are the agents that we just talked about. So again, in the distant past, this is what we utilized on the left-hand side. So for mild pain, in the past, the patient would be given PO opioid. So PO opioid, if the pain was more moderate, we'd give IV opioid for breakthrough, and would increase the doses of both as we started elevating to severe pain, and at that point would slap a fentanyl patch on the patient altogether. And then we would wonder why the patient was in respiratory depression, arrest. So, the code cards or the rapid responses were called for many of these patients in the past, but, as we created and we've moved forward, the new paradigm on the right-hand side is to utilize those recommendations from the anesthesiologist group to give the non-opioid analgesics as well as local blocks in the periphery, and to add step 1 with low doses of opioids. And once again, I cannot impress more emphatically that you need to lower your doses, and it will work. And then ultimately, if you get to severe pain, which this is an appropriate time where opioids should be used in conjunction with those other agents. So non-opioids is a foundation for acute pain. So yeah, how do we go about this? Well, multimodal analgesia, there are many things that we have to think about when we're implementing this practice, and it's the efficacy of these agents, patient characteristics for one, the age of the patient. Some of the nonsteroidals, like ketorolac, we have to reduce the dosing. If you look at organ dysfunctions, there are many patients that have kidney failure or liver failure, or so renal dosing of these agents is critically important. Comorbidities of the patient, as I said, gastric motility from the stress from anesthesia and surgical stress. We're going to decrease gastric motility, so therefore oral agents won't work as effectively as IV agents in that time frame. The ease of use of around-the-clock versus as needed. So making sure that we're giving these agents scheduled around the clock. And this is one of the most important things that I can dwell on, is the acquisition cost versus the global value of the agents that we select. I'm very fortunate to work in an environment here with a senior leadership team that looks at the global value of any clinical pathway that we develop, whatever tests and studies that we need, whatever pharmacologic agents that we utilize. In some instances, there might be an upfront cost that ultimately will have an increased value on the other end. So we have to be very cognizant of that as we go forward. So how do we go about this? Well, we have to understand how we're going to balance pain management and adverse events. Once again, as I said, the acquisition cost versus the global value. We really and truly need to develop clinical pathways or computerized order sets with decision support for providers in order to bring forward the evidence around the utilization of these specific agents. So there are multiple, we use the Meditech system here in Plymouth, in some of the hospitals that are with the medical center. The BID Medical Center has its own kind of homegrown software program, but we all have Meditechs, and there are multiple different platforms across the country. But however you can build in the different order sets with decision support, which is critical for providers to not miss ordering the appropriate agents. We have included pre- and post-operative order sets for various surgical procedures. We have adult and geriatric pain modules, which we've created. And another thing is that being a pharmacist and in charge of the clinical pharmacist here in Plymouth, I can't tell you how important it is to incorporate your clinical pharmacist at every site to monitor adherence to the pathways, to develop therapeutic interchanges where possible. And the clinical pharmacists are very, very, very valuable members of our multidisciplinary teams for every single indication, not just the management of pain. I have a few examples of our order sets here in Plymouth. We have an emergency department pain order set. This is the adult pain order set, which we're changing a little, but we have the non-opioid analgesics, the lower doses of injectable and PO opioids. And this is the same order set that we use for inpatients for a pain order set. We have preoperatively for all of our preoperative order sets. Our surgical service is well on board for all surgical specialties for multimodal analgesia. As you can see, this is an example of a pre-op total knee, total hip, where we use one of the coxibs preoperatively. And they order this, if you were scheduled for a procedure in 2 weeks, the provider can order this in his or her office as soon as the patient is scheduled, so that the pharmacist approves all of these maybe a week in advance, so there's no delay in preoperative medications. We have oxycodone slow release. We have pulled back, that we still utilize it for certain patients, but it's rarely that we give that because we saw some post-op nausea and vomiting with the oxycodone up front. We use pregabalin and sometimes gabapentin for these patients. We don't use that for all of our patients either because some of the patients are getting dizzy. So select patients will receive that. We use acetaminophen 1 gram IV for all of these patients, and scopolamine, as you can see, the other doses for those sets. Postoperatively for this knee set, I just call your attention to, we will use IV acetaminophen postoperatively along with the celecoxib. A lot of our patients they'll use tramadol for some of these joint patients as primary agents postoperatively. But we have scheduled it so these patients automatically receive 3 doses every 6 hours of IV acetaminophen, which automatically converts to PO acetaminophen for a total of 48 hours scheduled. We found that by using this dosage from IV to PO works extremely well and along with the other agents, we get extremely good pain control. That being said, another important piece of our multimodal as well as incorporation of our opioids in all of our order sets is that we monitor our utilization of Narcan. We created this report back in December of 2014. This is not for patients who come into our emergency room who are given Narcan in our emergency room. Basically what this is that if we administer any opioid in the hospital and the patient needs to be rescued with Narcan, a report prints in my office, it prints in the clinical coordinator's office. We have a full report written up on every one of these patients. We bring it to our pain stewardship committee, and this is by no means punitive. We have a full workup on what risk factors the patient have. As I commented before, we utilize the risk factors which were listed on the 2012 Joint Commission Sentinel Event Alert on opioids. We utilize all of those risk factors which may have caused the patient to have respiratory depression. We evaluate them, and then we give feedback to the specific service who administered the opioids in the first place. You know, we have a record of 2015. We had 10 events, 11 events in 16, 8 events in 17. So it's gone down a little bit, but you can see a medium-sized hospital that we don't have a large amount of events. Also, with the new guidelines put in place, pain stewardship committees, Joint Commission in their standard recommends evaluating Narcan utilization. So how do we reevaluate, redesign pain management? As Mackenzie said in the beginning, I was fortunate to be one of the committee members for the Mass Hospital Association. Not to belabor you with all of the intricacies of all of that, the CMO here in Plymouth, as well as the chief of anesthesia, was the co-chair of this committee. Him and I coordinated evaluation in the development of a toolkit with providers from core from BID Plymouth, as well as some of the Mass Hospital Association members. As you can see, in June of 2017, it was announced of our collaboration with Mass Hospital Association, as well as Mallinckrodt, that we created this. And as you can see kind of down below, us pilgrims down here in Plymouth were kind of given a blurb that we were able to coordinate this group. And it is a totally unbranded website, which is if you can see right here, www.painstewardship.com. If you are interested, you could go to that pain website for lots of important information. This is just kind of the group that we put together to evaluate all of the aspects. We made recommendations of patient brochures, of PowerPoint presentations for staff, information for patients, preoperative pain checklists, and various other instruments and tools to educate patients as well as providers. At this point, I was going to show you a video. If you click, when you go to the website, if you click right here, there's a 2-minute video which will tell you about all of the resources which are available on this website. One of the things that we're most proud of is the brochure of managing pain after surgery. You know, we give this pain brochure out to every single patient in pre-admission testing. You know, I've obtained copies of this brochure. We put it in all of our surgical specialties offices So when a patient gets scheduled for procedure, they receive this brochure, which, we have all of the literature which goes towards educating a patient that they're going to have tolerable pain, how there's non-pharmacologic protocols of repositioning, ice that we can use to treat pain, as well as non-opioid analgesics, as well as analgesics. So I really wish you would go to this website and take a look. So how do we implement these practice changes? Well, it has to be system-wide. In order to make this change, you have to have all of your primary folks at your committees. Quality and safety is critically important. C-suite, your leadership has to be involved. Back to the basics, and we want to make sure that we're treating pain to a functional goal. You want to establish your pain stewardship committee, as I stated before. You want to implement identify patients at risk. We put in a full-blown protocol for obstructive sleep apnea, which is for another time, but these are all of the elements that we had put in place to develop our new order sets and pain modules. Here is an institutional checklist for your use. I'm sure that they can share this checklist with you, that if you're in the implementation phase, that you can look at all of these elements for your pain stewardship committee. So developing a committee across the country, there are many folks who have called and looking for advice, but as you know, effective January 1st, it wasn't a suggestion anymore. Basically, Joint Commission is looking that you, as you can see from these elements, that you have a leadership group in place, that you're promoting safe use of opioids, that you're monitoring high-risk patients, that you're providing an easy way for your clinician to check the physician drug monitoring program. Here in our Meditech system, we've made it very easy for our physicians with a click to click right into they call it MassPad in Massachusetts, to check these, the website. So that being said, we have various initiatives that we have put together. These are the organizational goals. We look at pain management practices, evidence-based guidelines, external recommendation. These are all of the elements that we review at our pain stewardship committee. We put together, before we put the committee together, we put a steering committee together of our leaders, which were administrative leaders, quality leaders, physicians, and basically what direction should we go in. And as you can see from the topics that I have here, these are the kind of things that we have anticipated projects that we look at. We look at HCAP scores at every one of our meetings. Even though they're not included, we've seen extraordinarily good scores from all of our surgical specialties. I just got the report from 2017 from all of our surgical specialties. For the New England area, we fall in 95th percentile for the first two questions. Last question, we fall in the 89th percentile. I think that's extraordinary for the way we treat our pain and the process that we use for our surgical patients. We created pain stewardship breakfast rounds. So we have various specialties present every month. We talk about pain. The emergency room physicians will give their aspects on pain management. We've had our spine surgeons present. We've had our anesthesiologists present. We've had nurses present. So we have to keep our providers presenting to the staff to keep pain management in the forefront. This is just a flavor. We put together our protocol in our pain stewardship committee in May of 2016. I co-chair that with the medical director of our pain clinic, who is also one of our anesthesiologists. We have senior leaders on this pain stewardship committee, quality folks, administration. We also have, as I stated in the past, our patient care advocate, who is very important. And as you can see, those are the folks that we thought were important to be on our committee. We also have we're looking at addiction medicine, putting together a protocol around Suboxone in the perioperative period, as well as our hospitals being able to provide it for patients who are not in the hospital for a non other medical admission. We have our substance use abusers that can be put on Suboxone while they're in the hospital. We're in the process of putting together a pathway for that. Through our Pain Stewardship Committee, we've also just in the last, this is the last comment, we've created care plans for kind of our frequent flyers to the emergency room. You know, we get their PCPs involved. We put a plan together, which is basically signed with the patient. And this is our plan. And so for these are some patients who are seeking opioids. These are the things that we will do for you. These are the things that we won't do for you. And we actually include the PCP, the hospitalist, the ED physician, and the patient. Now, and most recently, we have created a number of care plans for patients who do require opioids in the emergency department, and that for whatever their disease state is, that they're being seen by a specialist, that they require opioids. We also put together one of these substance use care plans, which is available when the patient comes to the emergency room, of this is what we will do for you, which may incorporate the opioids that have been prescribed in the past for this patient. So these are very valuable to us, and we're still in the creation of these plans. So finally, I think I almost made it in 50 minutes, I think maybe 55, but we're back to our paradigm of patient care, and this is what it should have looked like in the beginning. And, you know, it's a challenge for us to get to this point, you know, meeting all of the parameters around quality, safety, and experience of care, you know, keeping our patient at our forefront, focusing on the patient, and that redesign of the practice of using opioids for all pain in the past is very, very difficult and difficult to change, and it requires a village and a baseline foundation of multiple specialists in order to provide that, incorporating the providers as well as administration as well as quality to get you to that point. As you can see from the maps of the United States that I presented in the beginning, you know, with all of these initiatives that we're all striving very hard to get to that point, and we still have a long way to go. So with that, I'll take some questions.
Wonderful. Thank you so much, Jimmy. As we're actually nearing the end of our presentation, if it's okay with you, I believe we'll have you actually follow up individually with our viewers who have submitted questions after the webinar, just to make sure everyone's question is still answered.
Yep.
Wonderful. Well, then that is all the time that we have left for today. I want to thank Jimmy for his excellent presentation and Malin Rock Pharmaceuticals for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.